Recently, the CDC released a new report highlighting that cases of chlamydia, gonorrhea, and syphilis have increased for the 6th consecutive year, reaching a new all-time high across the country. In particular, congenital syphilis cases have increased by 279% since 2015. Why is this happening? What is occurring at the New York State level, and how have our clinicians been responding to this crisis? I'm Linda Wang, and I'm your host for this episode of Any Positive Change. In this episode, I had the opportunity to speak with Margie Urban, an infectious disease physician who has been a leading expert on sexual health clinical education and has been on the front line of STI treatment and prevention in New York.
My name is Margie Urban, and I am an infectious disease physician. I live in Rochester, New York, and I am on the faculty at the University of Rochester School of Medicine here in Rochester. My area of interest in infectious diseases for many years has been sexually transmitted infections, and I wear a couple of different hats in that area. Right now, I'm actually sitting in my office at the Monroe County Sexually Transmitted Infection Clinic, where I have been the medical director of that clinic for many years now, about 20 some years. And I also wear the hat where I'm the principal investigator for the New York State AIDS Institute's Clinical Education Initiative Sexual Health Center of Excellence.
Wow, that's great. That's many different things that you're doing on a daily basis, Margie. But it sounds like everything that you do really converges around sexually transmitted infections and sexual health in general.
Yes, yeah. STIs and HIV, I would say.
Okay.
Yes, most of what I do. Yeah.
You know, I'd love to spend some time during today's episode talking with you and picking your brain really about what is happening both on a New York State and federal level with respect to sexually transmitted infections and sexual health. So maybe we can start with talking about what are the top concerns with respect to sexual health that all clinicians should be aware of, and are there any sexually transmitted infections that are rising in the U.S.?
Actually, almost all of them are rising in the U.S., so I guess that would be a top concern. The CDC actually released some new statistics on earlier this week, where they did some modeling using data from 2018, and they ended up coming out with a statistic that essentially 1 in 5 people in the U.S. have an STI at any given time. So for 2018, that totaled 68 million infections.
Wow.
That's not really all reportable sexually transmitted infections. That's usually what we think about when we think about the numbers for STIs, because they're the ones that we have data on. That's syphilis, gonorrhea, and chlamydia. And they have all gone up year after year, really, for the last several years. So that's true nationally and in New York State. I think another big concern, other than just sort of the rates rising, are that some of the infections that can be more complicated, like syphilis, which might have some complications downstream from the time that you get infected, where you might have long-term health consequences. They have been rising, and syphilis had really been at low points, some years ago. So that's a concern that they're rising. And as they rise, we've had actually infections in newborns at very high rates compared to the last 50 years. So that's a concern.
Yeah.
Another big concern, which is true of a lot of infectious diseases, is the rise of antimicrobial resistance, antibiotic resistance.
Right.
And that's a major worry with gonorrhea and with another sort of newer STI, one that we're maybe not as familiar with, known as Mycoplasma genitalium.
Margie, you mentioned that rates of sexually transmitted infections such as chlamydia, gonorrhea, and syphilis are rising year after year.
Right.
Can you share why this may be happening?
Well, that's a hard question to answer. One problem with sexually transmitted infections is that most of them actually don't cause very prominent symptoms. And so it's hard to know how many there are if you're not doing very widespread testing.
Mm-hmm.
So some people argue that maybe the rise is that our testing has become better. We actually have had some newer technologies over the last 10 years or so that are more sensitive, so they're more likely to diagnose an infection. And our patterns of testing have changed so that we do tests. It used to be if you got tested for STIs, you only got genital tests. But now, because people have lots of different kinds of sex, it depends on what kind of sex you're having, what
Right.
tests are done. So now there's pharyngeal tests and rectal tests that are also done. So that's one argument that maybe we're better at diagnosing.
Mm-hmm.
Some people also make the argument that PrEP has changed things. So PrEP is pre-exposure prophylaxis to prevent HIV. And as PrEP has rolled out, most people who take PrEP also get very routine STI tests. So usually every 3 months. And if they had previously had infections because they didn't have symptoms that were missed, but now we're checking 4 times a year, that could also contribute to the rise. Some studies have shown that some people on PrEP actually do change their behavior somewhat, so might be a little bit more at risk for getting infections that they wouldn't have had before. So that may be another reason. And there's lots of exploration into the role of stigma and other factors that impact health, like that are often called social determinants of health, and what their role might be in the rise in STIs. So factors like poverty or homelessness or substance use, and in particular, using substances, whether it's alcohol or some other substance, that has also been associated with some increase in STIs in the last few years.
Yeah, but it sounds like it's really multifactorial.
Yes, definitely multifactorial. Yeah. And I think would be hard to point to one thing.
Yeah, but also multifactorial in multiple directions, in the sense that it sounds like we have better tests that are more sensitive. We're able to pick up things that we weren't able to pick up years ago. And maybe also some increased access to care and diagnosis as a result of PrEP uptake, but also in the other direction as well, with stigma and other barriers to seeking care that may prevent people from discussing sexual health topics with their providers, and with that leading to diagnosis and treatment. So it sounds really complex.
Yes. And I guess another big factor is that over years, the public health funding that was devoted to local health departments and clinics that particularly treat STIs have decreased. So that's another reason that's often listed as maybe less access, particularly for people that lack access in other ways than maybe are uninsured or underinsured.
And how has STI treatment been impacted by antimicrobial resistance? Have there been any recent changes to treatment recommendations to respond to resistance patterns?
Yeah, well, gonorrhea is a good example. It's an organism, a bacteria that has adapted to avoid really every antibiotic that we have thrown at it. And until very recently, the CDC had recommended treating gonorrhea with 2 drugs using ceftriaxone at a dose of 250 milligrams plus azithromycin 1 gram, with the idea being that you would try to hit the organism from 2 different locations, kind of like we treat tuberculosis. And then that recommendation changed, and in the MMWR I think it was on December 17th, there were new gonorrhea treatment guidelines released And because of worries about the rise of antimicrobial resistance in gonorrhea and in many bacteria, the new recommendation is only to use a single drug, ceftriaxone, and not use azithromycin, and to increase the dose of that ceftriaxone to 500 milligrams. We actually used to treat gonorrhea with 125 milligrams of ceftriaxone. So this is the second time the dose has increased. If somebody also has co-infection with chlamydia, the new recommendation is to use doxycycline as the second agent rather than using azithromycin.
And is azithromycin now kind of off the table completely?
It's an alternate. It's off the table as dual treatment for gonorrhea without when you know that the person does not have chlamydia.
Mm-hmm.
But say you have somebody who does have both conditions, so they need a second antibiotic to treat chlamydia.
Mm-hmm.
The preferred antibiotic would be doxycycline, but if there was some worry that maybe there would be trouble taking an antibiotic, the dose of that is twice a day for a week. So some people just really can't bring themselves to take a pill every day. So if there's some worry that the person wouldn't be able to finish the drug, you could use azithromycin. Or doxycycline is generally avoided in pregnancy. So then azithromycin would be the alternate.
Later, I asked Margie about New York State-specific health alerts related to sexual health in 2020 and the impact that the COVID pandemic might have had on access to testing and treatment.
There was an alert that came out in July that this is from the State Department of Health, and it was a health advisory talking about increases in gonorrhea in Monroe County, which is where I am in Rochester, and also in the counties in the Capital District region, so in the counties surrounding Albany. And this alert noticed that in the first 3 months of the year, so really before COVID, there was already a pretty dramatic increase in the number of gonorrhea cases of around 70%. Compared to the first 3 months in 2019. So the alert really wanted to tell clinicians in these areas that if gonorrhea cases were going up, and then the pandemic happened, and many health facilities, as you know, really tried to minimize contact, and people stayed home and socially distanced. And because of the public health nature of many STI clinics, a number of those around the state really shut down or had very minimal hours because the personnel were also the same personnel who were working on COVID. So they really got redeployed. So this health alert was really saying, take note that gonorrhea is rising. We don't have the figures yet of for since COVID, but as I said earlier, a lot of times STIs are really minimally symptomatic. So if you're not doing a test, you won't get the diagnosis. So it's possible we're not really going to be able to tell what's actually happening in the community because testing shut down because of COVID in a lot of places. Gonorrhea in cis men who might have a urethritis, that is usually symptomatic. So most of those people would present for treatment. But gonorrhea in the throat or in other sites or in cis women is often asymptomatic. So if you weren't doing the testing, you might miss it. So the numbers for the rest of 2020 are going to be pretty hard to interpret, I think.
Yeah. So it sounds like it's really hard to know what happened during the pandemic and the lockdown and what kind of an impact it has on STI diagnosis. Yeah. Okay.
Yeah. Our clinic here was able to stay open. We actually have a contract. So we weren't the people who were redeployed to COVID the way so many were. So we were able to stay open, although we did modify things the way lots of places did with more telehealth and did some triaging, especially early in the spring. But we actually saw more gonorrhea this year than we did last year, 2020 compared to 2019, even though we saw only about 2/3 of the patients. So I think that increase is real in that we were seeing so many cases.
Yeah, that's definitely concerning. And have there been other health alerts at the New York State level?
Yeah, there was one other one around STIs that came out in October, also about Monroe County. And this one was about a rise in HIV cases that was noticed compared to last year. And it does turn out, at least in the preliminary data, that it looks like that was real, that there were more new HIV cases in 2020 than in 2019. In our sexual health clinic, we actually saw twice the number that we see. And it was in the county, again, these are preliminary data, but about a 60% increase.
Wow.
So some of those in the health alert, they were able to figure out that about 10% of the ones they were aware of in the health alert were new, very recent infections.
Mm-hmm.
They did give a few details that there were also quite a number that had a history of an STI
Mm-hmm.
in the past, about 40%. And there was also maybe slightly more who reported who reported that they used drugs.
Mm-hmm.
But again, this is all very preliminary, so it's hard to really make broad statements. But there was concern that there was a rise in HIV cases.
Hmm. And it sounds like potentially, I know everything is preliminary, but potentially in people who use drugs and also people who may have had a history of an STI.
Right.
Okay.
Right. Exactly. Now, so with HIV, I guess that's always, it depends on how you look at it. Like if somebody has HIV, we absolutely want them to have a diagnosis and to rapidly become treated and, really have a normal life expectancy. So in one sense,
Yeah.
it's good that the testing was done, even in this period of a pandemic, to pick those up. In another sense, especially with recent infection, that we have other ways to prevent HIV, like PrEP or PEP, and so sort of a failure of those things, and how could we have maybe intervened?
Mm-hmm.
So there's a lot of we're doing a lot of education locally in our community to help clinicians know that this is happening. The clinicians and the community, really, to get the word out.
Yeah, I'm sort of wondering, since that alert came out in October 2020, and that's sort of, what is that? That's like 6 months into the pandemic, right? And
Right.
I think we're all kind of wondering, could a rise in HIV cases, as the one you're describing, be related to decreased access to sterile injection equipment?
Yeah, and that's something we've brought up locally also. That is a concern.
Yeah.
There has been a rise in overdose visits and actual naloxone administration.
Mm-hmm.
So there may be some link there. Again, it's all still preliminary. But
Yeah. Given the rise in STIs and HIV, what is happening at the state level to address these rising cases?
yeah, actually, there's quite a bit happening. The State Department of Health, the AIDS Institute, has really, I think, embraced the concept of promoting sexual health as a way to tackle some of these issues. And I think there's a long history in the management of sexually transmitted diseases of there being a lot of stigma, of even stigma maybe trying to be a motivation to avoid an STI because of shame.
Mm-hmm.
And really the field has evolved to be one of health promotion, and the state health department has really embraced that. So there's been a lot of activity to get the word out to both clinicians and community members. So with the development of really education programs
Mm-hmm.
geared both at the community and clinicians. In policy ways, there have been changes. One example would be very recent changes in the law regarding expedited partner therapy.
Mm-hmm.
So I think people are really familiar with post-exposure prophylaxis to prevent HIV,
Right.
or maybe post-exposure prophylaxis to prevent hepatitis A or hepatitis B, but not so familiar, unless you're living in this STI world, of post-exposure prophylaxis to prevent STIs.
Mm-hmm.
But that's long been a mainstay of the management of STI epidemics, is to treat exposed partners regardless of their test result, because they could still be incubating infection.
Mm-hmm.
It didn't used to be called post-exposure prophylaxis. We called it epidemiologic treatment, but really it's PEP for STIs. And one way to do that is to allow the person, the patient who has the diagnosed STI, to deliver that therapy to their partner, rather than relying on the clinician to have to do that.
Mm-hmm.
And that's called expedited partner therapy. That had been legal in the state of New York for people who had chlamydial infection, where the partner could give a prescription or give actual medicine to the patient, could give it to their partner without the clinician ever seeing the partner.
Mm-hmm.
But in 2020, the state law changed, and now it's actually legal for gonorrhea, chlamydia, and trichomonas. So as part of the CEI program, we are really trying to get the word out that this has changed, and particularly in this era of COVID, where people are maybe reluctant to engage in healthcare, that this would be a way to get treatment to exposed partners.
So how can a provider send a second prescription to the pharmacy for the patient's partner in order to provide EPT?
The law actually specifies that the second prescription, if you know the name and date of birth and so on of the partner, you fill it out for that person. But even if you don't know that name, you can just write partner number 1 or partner A. The only requirement by the law is that you have the dose of the medicine that's needed, and the number of pills, and that you write in the text of the prescription EPT. And then by law, the prescriber is protected and the pharmacist is protected, that you're following the law, even though you don't actually have a chart on who the partner. It is also required as part of the law that you give educational materials about the medication and the need to be screened or seen in follow-up, to give to the partner. And the state health department and the New York City Health Department both have materials available on their website that you can download or have shipped to you as a provider, so that you can give that to the patient to give to their partner. And you can even do it by giving like a URL, so that the partner just needs to log in and view the educational materials.
That's great to hear. It sounds like such an important initiative to increase access to much needed treatment. I'm wondering how is this functionally possible through the electronic medical record system?
Yes, you have immediately gone to the main trouble with this. So this it's been legal for chlamydia in New York since 2010, and it's been recommended by CDC, I think, since 2006. So it's been done long before electronic records, and it was very easy when you had a paper prescription. There are now some institutions have developed workarounds within their electronic record to essentially have kind of a dummy chart where it would be an EPT chart. But with that, you would have to know the right pharmacy to send that electronic prescription. One other workaround has been that the state has allowed an exception to the rule for electronic prescriptions, and EPT is one of those exceptions. So you can actually order paper prescriptions to have just for the purpose of giving EPT prescriptions.
Okay.
One other way that you can do this is it's allowed by the law to actually give medication, not just a prescription, but to actually dispense the medication. And you have to follow all the rules about medications, but you can hand the index patient medications for their partner or partners for them to deliver to them the actual medicines.
Mm. But that's only possible if your clinic is able to dispense medications from the practice.
Correct.
Gotcha.
Which many dedicated STI clinics are.
Mm-hmm.
So that is something that is done, and that's actually in the studies. That's the most effective.
To physically give it to them.
Right.
Yeah.
Right. Exactly.
What are some other federal changes in sexual health recommendations that you can share with our audience?
There have been very strong recommendations because of, we mentioned earlier, congenital syphilis in a newborn, that locally, because of the rise in syphilis cases, our local institutions have changed the recommendations for screening for syphilis from just being in the first trimester to being in the first and third trimester and at delivery.
Mm-hmm.
And the New York State has recommended that in their through their HIV guidelines program, where they publish some syphilis and HIV guidelines, and have we've really promoted that recommendation through the CEI. CDC also sort of strongly encourages that approach, given the rise in syphilis cases. A little bit before 2020, there were some changes in, again, sort of in regulations and law that the state health department did in changing the definition of STIs so that HIV was included in the legal definition of sexually transmitted infections. And because adolescents are able to access treatment and prevention for STIs, it meant that adolescents could access PrEP and antiretroviral therapy and HPV vaccine without needing parental consent because of that sort of change in wording in the law.
Mm-hmm. Wow. Those all sound like they have the potential to really impact access for the better, which is really good to hear.
Yeah. There's been at both the federal and state level, I would say the last 2 years have been very active. Like if you go onto the CDC's website and look at what's new, you come up with a lot of things that have been released just really even just in the last few months compared to some years past. So there is also a new national strategic plan for tackling STIs for really the first time ever. And that was released on December 18th, I think. It was in that week in December in 2020. And that's been in the works for about 2 years and really went out for public comment a few months before the release. And really, from the STI perspective, is a pretty exciting, big picture approach to really tackling STIs in a very broad way with support from lots of different stakeholders, and does address some of the important concepts of getting at the populations who are most at risk and addressing some of the social determinants of health issues and stigma, and also looking to science to really bring some innovations, both in probably new antibiotics and vaccines and testing. So it's a pretty impressive document.
Yeah, it's so important. And I'd love to hear about how your clinic, and maybe other clinics that you're aware of, but we can start maybe with your clinic. How was it affected by the pandemic?
Well, like everything, it was a pretty dramatic effect, especially in the spring when really the whole community shut down. So we were a walk-in clinic, so much like an urgent care or an ED. So you never knew who was coming or how many people would be here or how many people would be in the waiting room. So we have over time, really come up with a series of different triage techniques so that we have sort of COVID is rampant kind of policies, middle COVID policies, and COVID is low policies, so that we go up or down in our triage methods. So we decided early on that we wouldn't close, and that we would attempt to keep everyone safe, patients and staff.
Mm-hmm.
And so we essentially created like a virtual waiting room in our parking lot. So we're in a setting where we're a freestanding clinic that does have a parking lot.
Mm-hmm.
So it used to be you just walked in, and now since COVID, we have initially a phone call from the door. It still can be walk-in, but without prior appointment. But we do screening on the phone, and we attempt to minimize how many people are in the waiting room. And we've essentially created a series of waiting rooms so that we don't have too many people. We're able to socially distance our patients or clients. We also, in sort of the period of high COVID, did more telehealth. So we did some syndromic management. So I mentioned that a lot of STIs are asymptomatic, but those that are symptomatic, you can make some educated guesses about what the causes would be.
Mm.
And we followed some CDC guidance about best ways to treat syndromally with oral medications. And we could either dispense that medication at the door if we were trying to really minimize, we had too many people in the waiting room, or even dispense it to a pharmacy, and the patient might even have the medication delivered to their home and never leave their home. We've done less of that as COVID has lessened. And initially, we also early on ended up just putting off routine screens. So patients that were feeling entirely well but just wanted to be tested, maybe we're on a sort of a testing schedule of every 3 to 6 months. And we put some of those off, or we arrange for some people to access home testing through another organization locally. But really, since early summer, we've not turned anyone away. We've been able to accommodate everyone who's coming. But we do now have, I just looked at the figures for late December, we're still about 20% down off of our pre-COVID volume. So these are people not seeking care, because we're not turning anyone away. So it's 20% less individuals seeking care, which I'm assuming is because of COVID.
Mm-hmm. That's great. So it sounds like you guys have really shifted very quickly to doing really a combination of telehealth, social distancing, and still seeing in person, and also just avoiding the clinical evaluation with diagnostic testing altogether for some things that could be done through syndromic management.
Right.
Okay.
Right. Exactly. Yeah.
That sounds like such an important response mechanism to minimize COVID exposure. Have there been are there other pearls from the transition that would be helpful for clinicians to hear, including specific treatment options that you have found to be more useful during this time?
Well, there were some pretty big changes in treatment. We talked earlier about the treatment of gonorrhea, and the recommended treatment has been an injection. So you really have to see the patient to do that, right? And when COVID was very, very high, and we were in sort of a major community lockdown, we were using oral treatments for gonorrhea, but at unusual doses, so that the oral medicine cefixime is sometimes recommended as an alternate. And the recommended dose used to be 400 milligrams, but it was increased to 800 milligrams because of concerns about promotion of resistance, antibiotic resistance. And cefixime, actually, there were some supply issues. You can't always get a supply of cefixime, and that really varies by geography. So cefpodoxime, another oral cephalosporin, was also recommended as an alternate at a twice a day dose, 400 milligrams twice a day, I think is the dose. So pharmacists weren't really familiar with that high dose of sulfixene. And so we ended up actually, when we would do an electronic prescription, we would have to put into the comments that this is a newly recommended dosing regimen by CDC, because we found that the pharmacies were refusing to fill the prescription. And then they would say, we'll call the ordering provider and you can come back tomorrow. So now we had a patient going out twice into the community during COVID when we're trying to avoid this. So that was our intervention to make sure that we could alert the local pharmacies about this change.
Mm-hmm. And that's not a medication that you typically carry in the clinic.
It was not. Since this, we have started to carry it because it is the medication that's recommended for EPT for gonorrhea.
Right.
So when that became an option for us, we were able to start ordering that.
Okay. Thank you so much for sharing that experience during COVID. If providers wanted more information about how to manage STI diagnosis and testing during the pandemic, where can they go to access these resources, including some of the clinical management tips you mentioned earlier?
They could go to ceitraining.org, and we go in now by Zoom mostly, but we will go into individual providers' clinics or offices or even larger grand round kind of facilities and do training about STIs or about dealing with STIs during COVID or updated STI guidelines, that kind of thing. We also have a number of trainings we've already done that are archived on that ceitraining.org website.
Mm-hmm.
And we also, there's a CEI line number where you can ask clinical questions. And we've gotten a lot of questions through that CEI line about both sort of tricky situations that have come up during COVID, where a couple of times we've gotten calls about syphilis cases where normally you would do a lumbar puncture. Mm-hmm. But because of the lockdown and the remote location of that particular patient, there's no access. And how do you handle these sorts of situations that just, didn't normally come up pre-pandemic? Mm-hmm. So we've gotten a number of sort of, what can we do given what we can do during COVID?
And finally, I asked Margie about what she is most looking forward to in the field of sexual health in the coming years.
I do think we're sort of at the beginning of an ending the epidemic kind of approach to STIs. So ending the epidemic, as you know, was the approach that New York State took to ending the HIV epidemic, and it's been tremendously effective in my view. I know we're not fully at the goal yet, but it's really been quite amazing how when you take such a broad approach and really dig in, how well it's worked. And I feel like we're sort of at that point with STIs where there's that kind of momentum that we're going to tackle it on this multi-pronged approach, or really not Band-Aids, but really tackle big issues. Mm-hmm. So I think it's probably a pretty exciting time. It seems like a hopeful time to me.
I agree.
In the STI field.
That's great. I really appreciate you speaking with me today. Any Positive Change, a drug user health podcast, is part of the New York State Clinical Education Initiative, or CEI. We are funded by the New York State AIDS Institute to provide progressive continuing medical education for clinicians to enhance their capacity to deliver high-quality healthcare services and to improve patient outcomes. CEI offers free CE-accredited trainings, conferences, clinical technical assistance, and tools on sexual health, HIV primary care and prevention, hepatitis C treatment, and drug user health. You can also speak with Dr. Margie Urban and other clinical specialists directly to discuss STI, PEP, PrEP, HIV, hepatitis C, and drug user health management by calling our CEI line at 1-866-637-2342. You can also find that number and more information at ceitraining.org.